I am here. Michael Beimer. Tim Berry.
Here.
Brad Gowdy.
Here.
Wanda Helgeson.
Here.
Dr. Kidd is excused at City Council. Chief Kidd.
Here.
Robbie Kirk.
Here.
Sherry McCoy.
Here.
Welcome.
Thank you.
Shalon Montgomery.
Here.
Welcome. Dr. Morber.
Here.
Sharon Knowles.
Here.
Randy Pettis.
Here.
Ricky Reeves.
Here.
Nick Sloan. Edwin Smith.
Here.
Kenneth Webb.
Here.
Micah Wilson.
Here.
Well, that's 3 missing. That's a quorum. We'll get started. So can Siri and Shalon, can you guys take 30 seconds, give us what you do, where you're at, introduce yourselves. These are new members to the committee, and welcome. Thank you, guys.
Thank you very much. My name is Sari McCoy, and I'm the Health Services Coordinator for Pflugerville Independent School District. This is quite unusual, I understand, for being a part of this. My background is emergency trauma nursing and pre-hospital before that. And so my passion is disaster and emergency preparedness. I serve on that committee within our school district, and we've developed emergency operation plans and EOCs and all that kind of fun stuff, trying to bridge the gap between education and the rest of us that are working really hard for emergency preparedness.
Excellent. Welcome.
My name is Shalon Montgomery. I am the Trauma and Emergency Management Director for Methodist Healthcare in San Antonio. Nurse, paramedic, and big component of EMTF, so I know most everybody in the room. And I'm super excited to be here.
Really glad to have you here too, Shalon. You guys, and Sherry, thank you. We do the committee appointments every year, and we have a 3-year term, so a third of the group fully at any given time is up for either reappointment and or to roll off and us appoint somebody else. And I say that because I get applications a lot, and I appreciate those who continue to apply. By the way, if you applied this time and didn't get on, it's 9 months till you'll apply again, and there's a pretty good chance at some point we're going to swap everybody out. The chairs have a great deal of latitude in this, and then we also have a great deal of restrictions from the department in some ways. So I have to have a wide diversity with respect to geography and with respect to background. So where your profession, where your genre is, if you're hospital-based, if you're fire-based, EMS, if you're all kinds of charts that I have to kind of make sure we're checking all the boxes. That's a little hot. That's close. That's a little less. There we go. Is that how? What do you guys think? Still a little feedback. I don't know if it's me. Maybe another mic. Like my mic's going down, but it's still there. All right. You guys can still hear me though? So thank you. I'll just talk closer when I need to make a point. 10-4. That's clear. Acknowledged. Charge the line. So wide diversity and making sure we do rural and urban, make sure we do hospital and EMS and fire and emergency management, to make sure we are representing all areas and aspects of the state and new disciplines as well. So I appreciate, Sarah, you applying. I am biased to people who come to the meetings when I'm selecting new members. What that means is that if I have not seen your smiling, shining face before, it's going to be very difficult for me to appoint you to this committee. If you can't make it to sit in the audience where you can do extra work and whatever you guys are doing out there on your phones, if you can't at least get here for the meetings regularly, going to be very difficult for me to decide that you're going to make the trip and the time and effort and commitment. I don't want to take a slot for somebody who's not willing to do that. So for those in the audience, thank you guys for participating. I know you find probably this is the most open GTAC committee. I believe it is. I'll go to a lot of the others, and I'm not big on coming up for public comments the whole time. You need to raise your hand, come on up here and say what you want to say, because I think we need to have an open environment and make sure we get everybody's. I'd have 100 people on this committee if I could call it a committee. That's what we did when we first started the task force. So enough of that. Any questions on that? You guys? All right, we'll get right to it. Work group reports. We'll table the TDMS. Dr. Kidd's not here. Chief, do you want to talk anything about the mass fatality efforts, where we're at with that, some of the conversations, or do you think that's premature?
Yeah.
All right. Emergency Medical Task Force report. We've had it swap up. Most of you guys are on the list. Where's Joe Pop? There he is. So Joe, come on up. We'll have a conversation about that real quickly. Joe Palfini is now the program manager, interim program manager for the EMTF State Coordination Office.
It sure doesn't say interim.
He sent me a picture and said we're not using Sterling anymore. They didn't put interim on my shirt like I told him to. So.
I told him that was on purpose.
So as you guys well know, Victor Wells has done an incredibly good job. You saw the emails when they went out. We haven't had a meeting since all this transpired, but Victor's promoted in our organization to an assistant division director, and he's running all of our field applications, including Fire MS, EPCR, crew scheduler. We have a ton of them. And so we're excited about Victor's growth in our organization. Selfishly, that's really good for our organization. I was lucky enough to be able to have a conversation with Joe Palfini as well. Many of you guys have worked with Joe over the years. And for Joe to return to STRAC and fill that void was kind of a 2-for-1 wonderful thing for everybody, I think. Absent Victor, I think Joe's, it was a perfect, I don't think we missed a beat. It didn't feel like we missed much of anything when Joe came in. And Joe, I'll turn it over to you. We have a bunch of stuff to talk about for the spring.
They can't hear you.
You're going to have to sit there.
Just sit down with your Kevin. He won't bite.
Okay.
Much.
Thank you. I have some pretty sporadic notes, so I'll have to beg your forgiveness for being in the job for 3 whole weeks. So, first of all, as far as the committees go, 2 of our committees met yesterday, the AMBUS work group and EMTF operations, which is combined with the mobile medical unit operations. The AMBUS folks are doing fantastic work. They continue to grow the program. Their main goals right now are listed in their minutes, but basically they're trying to do a better job of tracking a lot of their costs, so we know exactly what this program's costing not only the state and the EMTF program, but also the providers that are hosting the AMBUSs, maintenance, fuel, tires, that sort of thing, so that we can better budget for the future and make sure that we're taking care of the folks that are taking care of important assets.
How many of those buses are on fleet replacement plans right now?
Currently 6 out of the 13 are on a fleet replacement program.
Everybody see the gap in that? See that moment coming in about 4 years. So we need to be planning ahead right now.
And the discussion with the providers is not so much the chassis and that sort of thing, is more the medical interior, just wear and tear with use. It's particle board and stainless steel covering, like a lot of the inside of your ambulances. So you'll see that kind of thing get some wear.
They're working on that as well. They're also working to improve the training program for vehicle operators. So there's one group in particular that's working with DPS to get a driver training program through the driver's licensing folks, so that they can run the course and do all the backing and the hard stopping and get to see what the bus can actually do and feel like, and with a trainer it's a whole day deal that started in San Antonio, being delivered throughout the state. So it's going to be a big safety improvement for the program.
So they've been doing that for a while.
Correct.
How many do you think we've got through there? We had a number, but I don't remember off the top of my head. Does anybody remember?
I'd be lying. I want to say it's somewhere between 6.
I would say 50 or 60 people.
I wanted to
Does
say
that sound
60,
right?
but that's
Any of the coordinators off the top of your head? It's a swag. I don't really know.
Yeah, I think it's more than that.
I think there's 6 of them.
You think it's higher? So the other question is that do we know if that's a certification from DPS, or are we simply using their training facility?
Correct.
And that curriculum as a best practice?
it is the second of those two.
And is there value in us making that part of EVOC somehow, or making it like an EVOC AMBUS add-on or something? Is there?
There was some discussion, obviously not this last meeting, but the one that I was at, that making this part of the licensing process for those that were trying to get from C to B and that sort of thing. Class C license to a Class B license.
Right.
Making this kind of the last piece of that.
Any AMBUS operators in the room right now? Do you know if that affects insurance? Well, Micah, that was a good question. Do we know if that makes your insurance go up or down, or is it about the same, sort of already pretty high probably?
I don't think it changed at all.
Okay.
It was probably in litigation, though, if there was an accident.
Probably is a risk helper, right? It's a risk mitigation strategy, but it's probably not helping on a day-to-day point with especially if you're self-insured as a municipality or whatever. Okay.
And lastly, also continue to work on an operations guide that encompasses all the specialty missions that we've been trying to bring the AMBUS into, the neonatal, the critical care transports, and that sort of thing that we're finding from experience and lessons learned throughout the state, especially out like the West Texas area where they're moving critical patients during these ice storms and that sort of thing. How to configure that bus, how to make sure the providers that are riding along have the right information that they need to function efficiently, that sort of thing. So they're working on that as well. It's one of the work on.
Is Steve here?
In the back.
Steve, when you guys do that, it's becoming sort of the annual trek to Fort Stockton in the ice. Do you take it? Are those critical care paramedics? Are they taking nurses? Are they taking? They took a nurse.
2 years ago, when we first did this, we started off with a typical mix of paramedics and EMTs. That was the first leg of the trip, and then the second leg we switched to 100% paramedics. And then this year, when it started, since the air services were grounded, we added a flight RN to the mix. And then we also have stocked the ambulance for critical care equipment, where before, we didn't have that stuff. We were primarily looking at green and yellow patients. Now we know that because of how remote we are, that we may get critical patients. At one time, we transported 11 level 1 trauma patients in a bus, and that changes things for you, especially when you're going 120 miles.
In the snow.
In the snow. So you're doing like 80. 85. And you guys were still working with DPS and TxDOT. Did y'all do the same plowing thing this time, or did you have to do that for this?
No, we didn't have to do the plowing thing like we did a year ago. The roads weren't quite that bad. Our problem, and we were in close contact with DPS. They had their emergency operations center staffed, and so I was on the phone to them about every half hour. Our problem was we went to Fort Stockton, which is on I-10, and the original plan was to take patients to Midland, Odessa area, which is on I-20, and we didn't want to go back down to the split and come back up. So we were going to traverse roads that TxDOT doesn't manage. But TxDOT offered to find the county people and to drive the road prior to us getting onto it. They were a huge, huge help. And fortunately, that plan was scrapped. We brought them back to El Paso, so we didn't have to do that. But TxDOT has turned out to be quite a partner for us. We would have thought in far West Texas, we would have been dealing with ice and snow all the time.
So, for those in the room listening to this is where we start to see the nexus through the disaster districts, right? Through the DDCs, those DCs, and the state coordinators, bringing to bear other state assets. EMTF, we're having stronger in hurricane season. We have a real linkage in it west with USAR. Here's what I would consider a non-traditional partner with TxDOT, but that all happens through TDM. And Chief, I think your focus on emergency medical stuff, I know why, because you care about it and someone near you cares deeply about it. So we are blessed to have an emergency medicine physician pretty close to Chief Kidd every single day, and that's a good thing to make sure we keep the focus on EMTF and TDMS and a lot of those things. But every disaster has a medical component. Almost everything you ever have to deal with does that, and the integration we've seen over the last 5, 6, 8 years I think is fantastic, and I want to say thank you.
They actually came across a vehicle that had slid off the road, and the ambulance stopped, and the crew got out, and they pushed the vehicle back up onto the road because they were in the middle of nowhere.
Right.
Nobody to help them.
Check.
So the buses have the chain system. Do they have the?
Yes.
Yeah, I thought so. We spec that.
Yes.
Yeah. It's one of the things we actually may have done correctly. I thought at Texas, I was like, why are we putting the chain? It's probably the thing we did.
We like the jingle bell sound, but we apparently use them now, so.
Okay. Anything else on can we get to the training parts, Joe? Can we talk about the training missed ASM, the
Yes,
plan
yes.
for
That was all for
governor's
AMBUS.
split? Any
EMTF.
questions on that from the committee? I'm sorry. Any questions from the audience about that? Okay.
EMTF Ops met yesterday as well. They obviously reviewed what the AMBUS committee had done. They were working on some exercise information. So last month, not this.
It'd be easier if I had Shalon do it. I just thought about she's here. I'm sorry, I didn't think about that. Shalon chaired it, so let's kick it over to the person who ran the meeting, because Joe and I were at the ledge.
I did brief him just so y'all know it's working.
Yeah.
So OPSM met yesterday. We had a lot of good discussion about the upcoming trainings, especially the Baton Death March. So we also went over our goals and objectives for 2015. And having a multi-agency exercise was one of our goals. And we will be meeting that thanks to Steve and his folks. So everybody from every region has agreed to go at some point and play a role in the Baton Death March, so we will be having every region represented. So everybody was super excited about that. Also talked about Danny's SPI, and of course we're not all going this year, but he's getting some help from some other regions, and of course anything he needs, we told him to reach out and holler at us. And one of the other big goals that we were all very excited about is we just had a goal of making sure that everybody had 2 teams. And yesterday we went ahead and nailed that down, and we're going to ask that every region has at least 2 Type 3 teams as a 2015 goal. So by next December, all 8 regions need to have 2 teams.
Do you mean a red and a blue? When you say 2?
I don't know if they can call them red, blue, whatever, but just 2 separate Type 3 teams, deployable teams.
Okay. So the goal eventually would be to have a red, white, and blue capability on every at the Type 3 level.
Yeah, it's a Type 3 level.
We're going to shoot for 2 for a red and a white, or a red and a whichever color you pick.
Yeah, we just had a very generic goal of just 2 teams. We hadn't typed it prior to yesterday, but yesterday we all feel that we all need to, at the minimum, have 2 Type 3 teams.
Can we? I'd like to get the ops at the next ops meeting. I'd like to use the USAR. We need to walk them through how USAR does that. I don't know in the history of man. So did White went to Utah for the stamp. I mean, there's only that's like the only time I think in the history of man a whole team deployed that was the actual team. And it was to Utah to the Olympics.
Always pink.
It's always pink or purple when you go out the door, but the idea that you have a red team's on, and if 2 of the guys on red can't go, you fill them with first of all the white, and then the the blue guy past that. And that system works pretty well, but you got to have enough people to do that. And maybe we only have 2 for now. I get it, but I'd like you guys to see that instead of you need to see them as completely separate, and then you can pull over from them. Okay.
Yes.
Is that what you're doing? I just
Yes.
am repeating what
Yes.
you said. All right, good.
So more focus on the teams and the people. That's, we know, one of our big goals. Exercise. One of the other things that we are going to be putting together is kind of a matrix of where we've come. So we've made a whole lot of progress over the last 5 years, and we want to show some numbers and actual things that we've accomplished. So we're working on picking the data fields to put in there and show, year one we only had 5 people trained, and now we have X amount of people trained, and we had this much stuff, and now we have. So just kind of a timeline of where we started and where we've come, and just a visual to see how much progress we've actually made as the EMTF in Texas.
Yep. Those are numbers I could use quickly,
Okay.
by the way.
We'll put it together.
Any other questions for Shalon on that? I want to keep moving. We're going to go till 11. I'm just shifting by 30 or whatever it was. We're supposed to go from 9 to 10:30. We'll go from 9:30 or 9:45 to 11. So you guys, we're not, PD's not meeting, so we are going into their time frame. But that way you can get out of here. We're going to shoot for an hour and 5 minutes, just so you know, if you're wondering how long this will last. Hopefully. All right. Anything else on that report, Joe, that you feel strongly? Air Medical Working Group, I want to tackle that because we've gotten the MOAs signed with most of the providers. We haven't had a meeting. Mike is going to beat me up. We need the fixed wing guys. I'm going to their committee today. The fixed wing guys owe us some data back about rates, and we need to have a meeting. I just haven't put it together. That's on Joe and I to call that meeting together. That'll probably happen as a conference bridge. I don't know that we need to physically meet, but maybe we can do that in May. We'll talk about the schedule in May in a second anyway. That's going to come up. Infectious Disease Response Unit. We were asked at a previous GETAC meeting by Commissioner Gruber to put together a one-pager on what we thought made some sense for response to Ebola, and how we would specifically, how you could have caches of PPE for a hospital that's a kind of an initial hospital. There's a name for it, but I can't remember the 3 names. But the initial hospital, and to have maybe teams to go help in that hospital, and more importantly, how we're going to move those patients. What I'm now coining, I'm stealing it from another infectious disease person I heard say it, we're calling them now high consequence infectious disease. Because there are a lot of communicable diseases, there are a lot of infectious diseases, and I think we need to be cautious about chicken pox becoming something we're going to, there's a lot of infectious disease. There are not a lot of high consequence infectious disease. There are some, and those probably need to be defined. But that's a term I'd like to start socializing that, if you guys don't mind. It's a pretty cool term. Maybe it's already been used in infectious disease. I'm just learning about it. The main thing about the IDRU, it's a concept. It's not anything more really than a concept, is that you would have highly trained and highly equipped EMTF assets that would be an ambulance strike team that they sign up for extra duty. And in San Antonio, the San Antonio Fire Department, we're blessed to have a group of guys. Both hazmat stations now have an Ebolance that we took, and this cleaned up, and that actually responds as a secondary response asset on any, what we were coining EVD alerts. And so if there was an EVD alert, that triggered a bunch of stuff with hazmat, and including that Ebolance would respond. And in fact, the hazmat technician that drove it never even got out. He just pulled up, and then the 2 medics who were already involved in patient care brought the patient out. I believe a system like that needs to exist in every region. I think we need to have quick assets that can respond, that are highly trained, have additional training than a normal paramedic unit would have, and they have additional equipment, frankly. If you're going to have to ride 2 or 3 hours, I'd like more than, I think they need to have PAPRs, and I think they need, I'm not sure a lot of EMS agencies have PAPRs on board regularly for all trucks, so we need to identify those assets and have them agree to that. I believe that makes the most sense. I'll be curious if anybody else has an opinion of that from the committee or from the audience. Silence. Crickets.
So at EMTF, ops yesterday. We talked about having a discussion about infectious disease, since we were working on it outside of EMTF, that we needed to make sure that they are in that loop response, because they could be, because of the potential that that's the way it could flow out or something like that. Or we asked to put it on the agenda.
I'm curious if any of the EMS services are looking at the almost like the adult isolate kind of thing, because I know the federal government is, they're even going to purchase them for our VA that is only an outpatient center. So there's going to be a lot of funds coming to do that, but I didn't know if that was part of the discussion. It had not been in our pre-hospital group in our region.
So the those are called isopods, from what I understand.
Yes.
They're available. One of many.
It's like
I'm sure.
Kleenex, right? We
Right.
gotta be careful. Okay.
The one that we had actually made contact with was out of the UK, I think, and you couldn't put an order in several weeks ago because they're so backlogged. I mean, they're kind of a specialty novelty item that now everybody wanted. So, I think the major driver in that is the federal government that probably ordered a number with many zeros on the end, filling their capacity for a while. So I'm not sure. We've looked at them. The pricing is pretty impressive, but the weight is even more impressive. So
That's going to be across the board with any of the PPE for Ebola and stuff.
Correct.
You can fund whatever and provide all the money that you need. There's no product to get. The government's already taken it all.
yeah.
Does everybody agree with that?
Well, I mean, being that I work at a biocontainment center, we just did a drill with bringing an Ebola patient to us. The driver should never get out of the vehicle, and the two medics, we recommend PAPRs, no skin exposed, depending on what the patient's doing. So the ambulance is stripped down bare minimum, and the isopod, we have one, but it's really, I mean, put somebody in there for 3 or 4 hours is probably not a good idea, because there's like that much room from their face, especially if there's awake and moving around. So we ask them to strip it down and then put the two in the back of the PAPRs.
So,
We've had some significant discussion, because if you're trying to go any place by ground from El Paso,
Right.
we're talking 12 hours.
Yeah.
So, we've looked at, how we can hopscotch to change crews.
yeah.
Go
Yeah.
from facility A to facility B, stop, change crews, then to facility C, then that sort of stuff.
Is anybody aware of an effort to work on a strategy for the real-time movement, the logistics? What we're talking about right now it's called the actual work. It's not a theory, it's not a policy, it's real work, and it's got to be really done at the time. And I think that is anybody aware of there's work going on right now that, because I'm not aware of it, and I would, Joe?
So, you know that there was a CDC conference call last week, and that was the biggest, a national call, and that was the biggest discussion about these long transports. I can tell you that ASPR is looking to run with a contract similar to the National Ambulance contract, but for infectious patients, that they're going to be leading out pretty soon, or putting out pretty soon, so that there's contracts throughout the whole country where an ambulance service, like they do with the National Ambulance contract, which AMR currently holds, will come up with an ambulance in a given amount of time. So they're the two initiatives nationally, but there's no solution for the long term. There's no one talking about at the national level on how do you fix the long term, because it really is a local issue. I'm not so sure we want the federal government fixing a problem for Texas on these long transports.
I wouldn't even say long, right? I think I would call it transports. And we have an issue, if we have a patient, so I'm going to mention another strategy, because the reason we're having long transports is because right now our plan is to have 1 or 2 or 3 or 5 centers that have raised their hand and designated that. I believe, I would be curious what the audience, this is an editorial, I'm full of them it seems sometimes. I believe we need a strategy that identifies a key facility in every region, at least in every EMTF/health service region. I believe there needs to be a place that's going to take care of those patients.
A biocontainment.
A treatment hospital. Now, it may not be Emory. It may not be a Nebraska, right? I'm not, that's a,
Well, that's the term that the state came up with is treatment hospital.
Biocontainment center. We're the only one in the state because of Richardson just shut down.
right, the Richardson facility is not active. Okay, and how many beds?
Right now, safely, 2
2 patients, adults.
adults.
What is the
Well,
cost
what,
associated?
and Texas Children's,
They're building right now. They're not ready yet. They're building them. They're actively.
when we had our discussion about transport with Mr. Gruber, we told him our plan A was that the plane would come from the heavens and take that patient away, and he told me to mark that off our list, that, you know, we needed to be working on ground, so we're hoping the federal government will let us take them to Beaumont,
Michael?
to William Beaumont.
We could go tomorrow. UTMB did a full exercise, half-a-day exercise on patient transport from Memorial Hermann to UTMB. They do have a fairly well-developed protocol for that, for one large hospital to another, not from home to hospital.
Who did the transport?
Actually, I believe Baystar
Baystar
did it in this one, but Acadian was there, as was AMR. The transport was a cohorted ambulance that was already plasticized inside, had nothing exposed. Patient was only being given fluid. There was nothing for any interventions other than fluids. The protocol was lead ambulance, reserve ambulance. In the hot wash, we determined that probably it's best to have the follow ambulance have a crew completely decked out in PPE. A lead DPS and a follow DPS could be University of Texas Police because they could cross the boundaries if DPS is unavailable. In the hot wash, we determined that if at all possible, probably best to do this at midnight or when the traffic is low. DPS has complete authority on whether you run with lights or not, but the preference was not to draw attention to it by running with lights. Chris Collier had probably the most prescient statement of all. He left before the hot wash, but he left us with this, is to put a carbon monoxide detector in the back of the ambulance that's completely plasticized because it's right there by the exhaust. The last thing to bring up, because this was a UTMB thing, the OEM was just there as an observer, and clearly we want our jurisdictions along the route, the responders in our jurisdiction to know that Ebola is coming through in case there was a wreck, in case a responder had to go to a scene. But that's really all our role is in that. But we started talking about PAPRs, and I think PAPRs are probably a great idea in this environment, but there were 2 women that came down from the Galveston National Laboratory. They work with Ebola and all other things on a regular basis, and they came down to talk, to teach and observe the doffing of the PPE. She and I were talking about that, and she said the 3M PPEs with the pack and the
Breathe easy hoods.
Pardon?
Yeah, breathe easy. Go ahead.
Well, yeah, whatever. But she said those are probably not the right thing to be using in that closed environment because of the web belt, all the various little crevices that are on the PPEs. They used in a PPE
helmet mounted.
Pepper that's set on top of the head. I've never seen it.
The helmet mounted version.
Helmet mounted version inside the suit. And these are the people that work with this every day. And they said that the web belts and all
Chris?
create a really bad vector for not being able to get rid of it.
Chris?
To kind of go along and give you an idea of what he's talking about. So we have developed a draft plan in our region. We partnered with 3 of our private providers to assist jurisdictions for facility transport and to be able to go out to sea, to be able to pick up if a jurisdiction especially smaller jurisdictions that only run 1 to 2 ambulances, because that's taxing on them to have to pull that ambulance out of service, have to keep that crew out. If they can identify that they might have a potential Ebola patient, we have an ambulance rotation set up between our 3 private providers, which is Acadian, Baystar, and AMR in our region, and they have a week-to-week rotation that one's up, one's on reserve, one's out. And then that's for going out to scenes to assist with transporting that patient to a facility or the inter-facility transport part. We did exercise that. We tabletop it. We did do a full-scale trial with UTMB to test that transport process, UTMB's receiving process on that patient.
Do they have specific ambulances that they've gutted and?
They have each one has.
Chris, can you come up to the mic? We need to put, y'all need to come up to the mic when we can. This is good stuff. Who is doing similar things to what Chris is talking about in your area? Raise your hand. Okay.
Yes, each provider has identified ambulances that they do have pre-cut plastic, either wrapped or ready to go when called, and the crews on. They know which crews are trained and up on standby for when it's their week to be on.
So I'm not shooting holes in this, but I'm going to sort of shoot holes in it. So is it the inter-facility transport part makes sense? I mean, I actually get that. They're already in a facility. But in a 911 call, and it's 60 miles away, 50 miles away, that private's going to respond to that 911 call because the 911 service provider is already on scene. And that's just going to sit in stasis until that provider gets there. Then they're going to transport it back to town?
In theory, yes, that would be, I guess it's going to depend on the state of the patient.
Yes,
that's a long.
It is a long time.
So I tend to be sort of the simplest plan is probably the best plan that's going to actually happen. Is I think they're going to get there and they're going to end up having to transport, and they're going to transport to the smaller facility, and now the patient's going to be not stranded, but they're going to be at this other facility, and that we haven't even tested them yet. I mean, there's a lot of questions, right? And so my worry my main worry is I think we need to plan so that every provider knows this is a real risk, no different than AIDS, no different than, HIV, any of the other things we have to deal with on a regular basis, and that they're prepared to deal with that in even the smallest of communities. And that we as a state body are trying to help them be prepared, number one, with equipment and with all that stuff. We can't outfit every single ambulance with PAPRs, right? So there is going to have to be some consolidation and sharing of those things. But at the end of the day, my sense is if we don't plan for a small rural place, picking the patient up and taking to that small rural facility, we're missing a big chunk of what could happen. I don't know if that makes any.
No, that's definitely on our list of concerns because that's probably going to happen. And so we're trying to figure out ways to mitigate that.
Once they transport that patient, is that ambulance, is it toast?
It's going to be decon.
We'll see. It's not. It's going to go through their.
We have a Zymac, or we're Zymacing them. So I had another question about the transport. Y'all didn't have any hazmat assets following behind? Who does, if they have to get out of the ambulance, who does any, bleach for doing the doffing? Who did that?
UTMB assisted with that.
Followed them behind?
Well, we took them to another area to get.
No. So you're Wanda. I mean, I have this vision of a rest area and people tweeting out, driving by, because there's dudes in moon suits out behind the ambulance because someone's going to have to go to the bathroom. It doesn't have to be an emergency. I mean, you're not going to I'm not driving from El Paso to San Antonio in a suit. I mean,
we did not have a hazmat team, but we did have a chase ambulances and people to relieve them to come in and suit up for that.
Our plan right now is to have a Suburban or a F-550 or something with extra stuff in it that's got hazmat dudes, and they're falling behind with all the stuff they need to help do the decon as they're doffing, right? Yeah. And then that's all going to have to be triple. I mean, there's a lot of stuff here where I think it's a bigger thing than simply how do we take care of the patient and how do we make sure we have an extra ambulance to have some dudes pop in. And maybe I'm overthinking it, but I'm
there are a lot of